I changed how I record things, so when I upload them finally to YouTube, Ortho is going to have 3 parts to it because I have to record the first break, whatever, then I break, but I stop recording, then I record again for the second half. So it comes up as 2 different lectures, but it's just one. Don't freak out. If you see part 3, you're like, where was part 3? I don't remember that, but it's just the second half of class. Okay, so today we're going to talk about neuro. We have today and we have Thursday, and then your exams in a week for the renal, musculoskeletal, and neuro. So let's go into neuro. Now, some of the neuro stuff we are going to cover next winter in neuro for CMS. We just don't have the time to really draw out a lot of those neuro pathways, so we're going to save it for CMS in the winter. We don't get them. So again, let's just kind of review. Detect, analyze, and transmit information is the main job of our nervous system. Just think of it as like a computer. The brain's the computer. We have inputs. Your mouse input, the pen input are all going in. The output is a printer. Your screen is an output. What are you seeing? And that's what our brain basically does. Everything's controlled via your neurons and whatnot. So normal structure and function of our nervous system. Remember, we have our neurons, the dendrite that receive information, the cell body, which has the nucleus, and we have the axon, and that is the length of the entire neuron. And that's what transmits the impulses or receives them back to the brain. But usually, remember, axonal transport is unidirectional for the most part. Most of our neurons are going to be multipolar. So they receive many types of input from many different neurons, and they all converge into one, and that sends the signal out. And we have obviously bipolar. Retina is an example of those bipolar neurons, and we have special sensory ganglia as well, and that spinal cord and periphery. So we have a lot of branching going on. So one neuron with thousands of inputs to send that information going towards the brain. Axon branching allows several target cells to receive information from one neuron, so it's almost like a backup system. We have the synapses, and that is where neurotransmitters are to transmit the electrical signal from one neuron to the next, or one neuron to the target tissue, wherever we're innervating. So we have our synapses. Remember, near the synapses is where all of our calcium channels are. Why is that important that our calcium channels are located at the end of the axon? Exocytosis, that is where all of our neurotransmitters are. We need calcium, and that allows the process of neurotransmitters to be released. Remember, we have excitatory neurotransmitters and inhibitory ones. Make sure you remember the excitatory ones are glutamate is the biggest one in the nervous system. And what they do is allow influx of sodium or calcium. These are positively charged ions. They're going to cause depolarization of that cell. The major inhibitory neurotransmitter is GABA. And remember, GABA opens those chloride channels. And when those chloride channels open up, what happens to the membrane potential? Does it get more negative or more positive? More negative. We're adding chloride, Cl minus. So become more and more negative. Are we coming closer or further away from the threshold? Further away, harder to get to the threshold, harder to get an impulse. It's inhibitory. And termination of that neurotransmitter, either we reuptake the neurotransmitter, we break it down, or taken up by other cells or metabolized. Remember, here is just how it looks. Impulse comes down this direction. Here are the calcium channels all along there, and we have our vesicles to be released that has all of the neurotransmitter inside to go to the postsynaptic membrane where it has its effect. And here's just an example again with regards to with our synapses, with our inhibitory and the excitatory, the glutamate. So always remember, GABA is inhibitory, glutamate is excitatory. Several cells, astrocytes, Remember, what is that? What's the main purpose of the astrocytes? Blood-brain barrier. It has those podocytes, the same thing that happens in the kidneys. The podocytes, those foot processes that provide those tight fenestrations. So astrocytes are that. They also provide some like scaffolding, like the structural support. They kind of hold different neurons, provide structure to all the neurons. So you can see here the different example of these astrocytes. Oligodendrocytes and Schwann cells are the same thing. They both make myelin. Just remember, one is in the CNS and one is the PNS. We've gone over that many times. We can skip that. Microglia are the immune system for our brain and spinal cord and certain nervous system. Those are the cells that do it. But again, obviously, we have to get rid of any pathogens. We don't want anything in the brain. And if they do, the microglia will help take care of it. Moving on to functional neuroanatomy, we have our motor system. Motor system is the cerebral or motor cortex of the brain. The motor system only has two types of nerves, an upper motor neuron and a lower motor neuron. That's it. Upper motor neuron starts in the brain, goes down, then it synapses at the spinal cord level to produce a lower motor neuron, which goes to wherever it's got to go. So a way to remember that, we have a receptacle where you plug in your power. The wire that comes from the breaker box that goes to the outlet is the upper motor neuron. The outlet, if you plug in like your phone to charge, that is the lower motor neuron. The synapse is in the outlet. You plug them in. So the lower motor neuron is when you plug in your phone is the lower motor neuron. The upper motor neuron is what provides the power to that outlet in the first place. So if I have issues coming from the breaker box, my brain, to the outlet on my table, the lower motor neuron, whenever I plug into that, may not work as well because there's no power to that outlet. There's nothing going to that synapse. Likewise, if we know the upper motor neuron is working just fine, but let's say you've been using your charger too much, and now it's starting to bend and crease and cause issues in the wire that you're using to charge your phone. What's going to happen if that wire doesn't work as well? What's not going to happen? Your phone's not going to charge. That is what lower motor neuron damage is. It's damage to the wire itself, going to the phone, not allowing the phone to work because the wire is damaged. The upper motor neuron is still fine. There's still power going to that outlet. If you change the power, change the wire, it's going to work. But that's what a lower motor neuron is. The axons from the upper motor neuron make up the pyramidal tracts. So if you remember from physio, we talked about the pyramidal motor system. So anything you hear about the pyramids is always going to be the motor system. If you ever hear anything called extrapyramidal side effects, or EPS, those are neurological problems from outside the pyramids. All of your cerebellar function, coordinated movements don't involve the motor tracts for the most part. So we have corticospinal, that's the brain to the spinal cord. We also have corticobulbar, which is the brain to the medulla. Okay. Your extrapyramidal neurons, caudate nucleus is here, your putamen, subthalamic nuclei, substantia nigra is here. Okay, that's where all the dopamine is stored. And when you're lacking in dopamine, you have problems with your extrapyramidal side effects. Okay, lower motor neurons, skeletal muscles, that's what it actually innervates the skeletal muscle, is the lower motor neuron. So you can think of your phone as the muscle. That's the target tissue for those lower motor neurons. Each axon has about 200 muscle fibers it connects with, and that's called the motor unit. And there are specific segments. We all have it mapped out from anatomy already. And we know that they're organized in plexuses, so they have one peripheral nerve. Again, lower motor neuron is the final common pathway for all voluntary movement. Okay, it's the motor system. This is under voluntary control. Damage to the lower motor neuron or the axons will cause flaccid weakness of the innervated muscle. You have to have nerves innervating your muscles or they will not work. They need to be excited. Okay. Muscle tone or resistance to passive movement is reduced. DTRs are impaired or lost because that little neural pathway is broken now. That lower motor neuron is damaged. The muscle tone or resist, again, DTR is impaired. Neuromuscular junction, where the nerve and the muscles touch. That's usually going to be impaired with some people. The nerve will pull off the muscle. You see that with ALS, amyotrophic lateral sclerosis. The nerve retracts and atrophies and it pulls away from the muscle. And wherever that happens is where you're going to have your muscle problems. Acetylcholine for all skeletal muscles. And it binds to what type of receptor? Nicotinic or muscarinic? Okay. And removed via acetylcholinesterase. Neuromuscular junction. There are a couple of things that happen at the junction that can cause problems. First one, Lambert-Eaton myasthenic syndrome. Antibodies to the calcium channels. That's what Lambert-Eaton is. If I have antibody to the calcium channels, what is never going to be released or released in smaller quantities? Your neurotransmitters. So therefore, if neurotransmitter movement is reduced, motor function is going to be reduced as well because you don't have enough neurotransmitter to do it. Another case of this impaired calcium channel function also occurs with these aminoglycoside antibiotics, things that end in mycin, streptomycin, gentamicin. Okay, they can also have ototoxic problems, but also movement problems. Impaired calcium channels, again, so it's similar to Lambert-Eaton. Lambert-Eaton is more of a autoimmune problem because you have antibodies attacking yourself, but aminoglycoside is just because you took the antibiotics. Once you stop it, it should go back to normal. Clostridium botulinum, Botox. Okay, prevents neurotransmitter release at both neuromuscular and parasympathetic cholinergic synapses. Botox prevents the release of the neurotransmitter. So it blocks acetylcholine from being released. If it doesn't be released, there's no contraction, therefore you don't get wrinkles. And that's the thought behind Botox. The last neuromuscular junction problem is myasthenia gravis. Autoantibodies to the nicotinic acetylcholine receptors, and they inhibit receptor function. Okay, so we're going to, myasthenia gravis attacks the receptors on the postsynaptic side, so they will never have an effect. So this is a really good summary slide. Here's your Lambert-Eaton aminoglycosides, there's your Botox, and there's your myasthenia gravis. All disorders of the neuromuscular junction. When you're looking at neuro, and we'll do this a lot more when we have a lot more diseases to talk about when we get to the winter, your job is to figure out with any type of neurological problem, is this a muscle problem? Is it a nerve problem? Is it a CNS problem, like when you get to the spinal cord? Or is it a brain problem? Where is the problem coming from? Is the brain causing you to have muscle problems? Is it the muscle themselves causing you to have muscle problems? You don't know when you first see a patient complaining of problems walking. You got to figure out, is this a nerve, neuromuscular junction, muscle, or brain problem? So these are examples of neuromuscular junction problems. Upper motor neurons, they start in the cortex, in the motor cortex, of course, and they terminate within the medulla or the spinal cord, depending on where they're going for the muscles. Groups of all of our neurons are organized in these columns, and upper motor neuron lesions cause a pattern of limb weakness and change in tone. Arms are going to be flexed and pronated, so like this. Okay, so if you watched Tua over the last weekend, He got his like third or fourth concussion. When he lands on the ground, they all go like this. There's a certain type of posturing, which we'll talk about probably more in the winter. But when they go like this, it's a better prognosis. If they're like this and down and their arms are flexed or extended, that's a worse prognosis. So as long as their arms are up like this, better prognosis for recovery, but it's arms out like that, it's worse. So you can see here, the motor neuron starts in the motor cortex. The same nerve goes all the way down, all the way down, all the way down, all the way down, till it gets to the area of wherever that one needs to synapse. And then in the spinal cord is where it occurs, and it goes to the muscle. We will learn all about these crossovers in the winter, not right now. Okay, moving on to brain issues. Gray matter, why is it gray? What does it lack? Myelin, which means the gray matter is composed of what? Cell bodies or the axons? Cell bodies. The axons are covered in myelin, which is white, and that's why you have white matter, because they're myelinated axons. Gray matter, all the cell bodies. Okay. Cerebellum, coordination of movement, stance and gait, regulation of muscle tone. That's why you'll start seeing issues with movement and how they show up then. Ataxia is a delayed onset of movement. So what happens is with people with Parkinson's, they can't control their acceleration or deceleration, so they're always like going forward and then kind of shuffling and then trying to shuffle forward and stop, slow down. That's what happens with Parkinson's. Their control of their movements, fine tune of control is lost, and they can't coordinate themselves. So they have what's called an intention tremor, and they have dysmetria, overshooting. What PD lab skill do you guys do to look for overshoot? Finger or nose, right? That's why you have to extend your arm all the way, because you have to make sure that the arm's extended. Because if you didn't extend the arm all the way to you, then my arm went too forward, I would think, oh, you overshot my arm, you have Parkinson's. No, it's just because you didn't do it right. Arm has to be extended. The patient's arm has to be extended all the way. Not your arm, the patient's arm. Hypotonia, low muscle tone also results. If the lesion is unilateral in the cerebellum, they have the problem on the same side. When we get to neuro, in the winter mainly, what we're going to want to find out is the issue they're having ipsilateral, which is the same side. So ipsi, same side, or is this contralateral, opposite? Contralateral loss is the opposite side. Ipsilateral loss is the same side of the lesion. So cerebellar dysfunction, they have a lesion on the right side of the cerebellum, they're going to have a problem with the right side of their body with those type of movements. If the lesion gets to the midbrain, they may have problems with opposite issues as well because of when the crossover happens. We don't really go on crossover too much, but you all know by now that the right side of your brain controls the left side of your body because there is a crossover that happens in the lower medulla. Okay. Basal ganglia, initiation, amplitude, speed of movements. So therefore, when you guys are doing your gait analysis, what do you have them do? Walk. But what is also part of the instructions? Turning around too, right? You want them to see them walk into a corner. How do they turn around? And so forth. You want to see how they're walking, because if they have coordination problems, they can't just pivot on their foot to turn around and do that. They're going to lose balance and fall. So what do they do when they get to a corner? They shuffle. Because it's easier for them, and they'll start walking again. They shuffle. Okay? Basal ganglia issues. So motor defects, bradykinesia, slowing of movement, akinesia, loss of voluntary movements. And they may lose also some postural reflexes, so they'll lose some equilibrium. They also get increased activation of the motor system to try and compensate. It's like a rigidity, tremor, involuntary movements, chorea-like dance movements where they start twitching and they can't control it. That's chorea. They have no control. They can be violent in their flailing. It could be left arm, like the arms or legs, either one. Athetosis is handwriting. Usually their hands just keep doing this, like it's called like a snake-like or serpent-like, where the hand just keeps twisting. That's athetosis. Bulismus is more violent chorea, where like they really shake everything. Dystonia is like a twitch, repetitive muscle contractions, or like a tick. Neurotransmitters in the basal ganglia include acetylcholine, GABA, and dopamine. So those are the major neurotransmitters with the basal ganglia. So here is our brain, and we have it all mapped out again. So there is our central sulcus, and that divides the primary motor cortex, or the precentral. And we have the or the sensory, and that is postcentral gyrus, or postcentral or precentral. Precentral is always the motor. Postcentral is always sensory. We have our prefrontal area. That's all of our decisions and social graces and cues and whatnot. Remember, our visual is in the back occipital cortex. We have our Wernicke's area. What is Wernicke's? Speech or comprehension? Speech or comprehension? Comprehension. Wernicke's patients, they can speak normal, they just don't make any sense when they speak. Wernicke's area is comprehension. Broca's area is motor. Okay? When they have the inability to form the words, remember, your mouth has a lot of muscles that all have to move in order for you to speak. And if they had issues or stroke to that area, damage to that Broca's area, the motor function of speaking is going to be altered. They know what they want to say, they just can't say it. Okay, moving down from the brain to the spinal cord. Extends from the base of the skull down the canal to the second lumbar vertebra, and has our meninges. So make sure you remember dura, arachnoid, and pia maters are the order of the meninges. The dura mater is the outermost layer. The pia mater is the innermost layer. So just remember DAP, DAP. And spinal cord has our gray matter, white matter. Always remember, the dorsal posterior horn is always afferent sensory. The dorsal horn of the spinal cord is always going to be sensory. The ventral anterior horn is always going to be efferent motor. Connects the motor portion to the spinal nerve. Okay, those are always going to be that direction. The spinal nerve roots are called mixed nerves because you have the sensory coming from one area, we have the motor coming from the other area, and they make the mixed nerve. It's got sensory and motor built into it. It's a mixed nerve. Okay, makes sense? Everyone see the spinal cord? And here's your example again, just in a normal way to write it. So we have our sensory on the dorsal, motor on the ventral, and we have our mixed spinal nerve, which carries both tracks out to wherever it's got to go. So that is the spinal cord. Here's about the meninges. Again, dura, arachnoid, and pia. Also remember the spinal cord, we have our all the innervations, parasympathetic, sympathetic innervations off the spinal cord. Remember also where all the parasympathetic ones are, what cranial nerves are parasympathetic, and other words. So this is a breakdown again of summary slide of our central nervous system. This is a breakdown of the different neurotransmitters involved with each type of parasympathetic and sympathetic system. This is a review from physio as well. Okay, let's get to our first motor neuron disease, ALS. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. This is what Stephen Hawking had, ALS. ALS is a motor problem only, nothing with cognition. And think of Stephen Hawking, came with all his theories. But motor system-wise, he couldn't do anything. But his brain was still working, he was able to do everything. It's a motor problem only, nothing else. Most common form of the motor neuron disease, age of onset between 40 and 60. ALS is a mixed upper and lower motor neuron disease. They get both. Initial symptoms are due to muscle weakness. They'll say, well, I can't really hold my mug of coffee anymore in my hand. It drops out of my hand. That's the beginning part of muscle weakness. They say, I'm having trouble swallowing. I'm coughing when I'm drinking liquids. That's a form of muscle weakness in the throat caused by ALS. So where the symptoms of ALS depend on what nerves are involved. If it's the nerves of the mouth and the breathing, then you're going to have problems breathing, and you're worry about airway support. If it's the muscles of the legs, then you're not going to be able to walk, and so on and so forth. So it depends on where you're having these problems. Complaints are often bilateral and symmetrical. Bulbar involvement manifests as swallowing, chewing, breathing, all those problems. Extraocular muscles and sphincters are spared. So amyotrophic refers to muscle wasting from that lateral motor neuron loss. The lateral sclerosis refers to the upper motor neuron loss. So amyotrophic refers to the lower motor neuron problem. The lateral sclerosis refers to the damage to the upper motor neuron. That's why ALS is a mixed problem, upper and lower. It destroys both of them. And this is basically what happens with ALS. You can see how that axon is becoming atrophied and thinned, and it'll eventually start pulling away from the muscle, and it won't innervate the muscle anymore. No innervation, no movement. Nothing's going to happen. It's a progressive disease, usually fatal within 3 to 5 years of diagnosis. Death often results from pulmonary issues because they're having problems breathing. If you're having problems breathing, not only can you not get the air into your lungs, but you don't have sufficient breath to get all the stuff out. Remember, part of the exhalation process is to get rid of pathogens out of their airways through coughing or mucus production, coughing it out. These patients can't do that. They don't have the muscle function. So those things just remain trapped in the lungs, proliferate, multiply, spread, and you get pulmonary infections. Frequently begins in the hands, feet, or limbs, and then spreads inwards. So you gotta get, again, I can't hold that mug of coffee anymore, something's going on. Muscles get weaker eventually, and eventually you're gonna get swallowing and chewing affected, and then breathing, and then you have to worry about airway management. Do you put them on a vent to get a trach put in? Quality of life and all that fun stuff. Very important again, doesn't affect bladder or bowel control or cognition. Your thinking is all going to be fine. So what's going on with ALS? Selective degeneration of motor neurons. Remember, this is a mixed one, so it happens in the upper and it happens in the lower as well. Upper primary motor cortex, and the lower, it's going to happen in the anterolateral horn of the spinal cord. I'll show you where. That's where like ALS can have their problems. Anterolateral, okay, all over this part. If you look, what nerve is right there? Motor. That's why it affects motor only. It's anterolateral, nothing posterior. What's in the posterior side of the spinal cord? Sensory. We're not affecting that side, just the anterolateral, which is the motor part, motor only with ALS. And Okay, so they get disease, accumulation of too many intermediate filaments in the cell body and axons. Normally are in cells to provide structure, but we have too much of it, causes destruction of that nerve instead of keeping it structurally sound. Now we have too many, causes destruction. Very little inflammation is noted. This is just a progressive deterioration disease, not an inflammatory process, so no swelling is going to occur, no other signs of inflammation. What are some possible causes of ALS? One they think is glutamate is the problem. Remember, it's an excitatory neurotransmitter. We don't want this neurotransmitter going crazy and uncontrolled. It's going to stimulate the brain too much, causing problems like potentially ALS. So glutamate is not cleared enough. It sticks around longer. Too much glutamate, overstimulation, and you destroy the nerve. You pretty much overstimulate the nerve and you burn it out. So it's not going to work. Okay, there is some hereditary involvement as well with ALS. They have some mutations and it causes disruption in the neurons. So what are they going to present with? Weakness, usually in a hand. Difficulty walking. They may say they're tripping more easily. Why are they tripping? When you look at your foot has to sweep the ground to get across. So your foot has to be dorsiflexed or plantar flexed to get around the ground. Dorsiflex, right? Well, if you have weak dorsiflexion, it's called foot drop. And when you walk, your toe is going to drag on the floor and you're going to fall. That's why you do heel walking. Can they keep plantar flexion or dorsiflexion for a while? If they can't, they'll walk on the flat foot. That's foot drop. That's a sign of lumbar damage. Clumsiness in the hands because they can't squeeze things. They drop them easily. Fasciculations are twitches that are going on. Muscle stiffness, spasticity. Speech becomes a problem later on. Swallowing. And then eventually the muscles and the postural muscles cease to function and they can't keep their head up anymore because the cervical muscles aren't working. Complications of ALS. Breathing is the biggest one. You got to watch out for that. Once those respiratory muscles start to become affected, they can't maintain their airway and their breathing anymore. If they have any problems speaking, you may need to start looking at some alternative forms of ways to communicate. Eating difficulties are going to arise depending on when those muscles of respiration or swallowing start to get affected. Therefore, more prone to aspiration pneumonia. That's when you choke on your food and you breathe in and the food particles go into the lungs. So you've aspirated the contents and that food stuff that's in your lungs now, or gastric juices, are going to cause problems in your lungs and cause issues there. They may have frontotemporal dementia with this as well. And that if they do have any type of cognition problems with ALS, it's got to be that, because remember, ALS is a motor problem, not a sensory cognition problem. So here's another picture. Here is the denervation. That nerve has pulled away from the muscle, no longer going to innervate that muscle. If muscles are not innervated, they're going to atrophy. If you don't use it, you lose it. And that's why with these patients, their muscles atrophy because there's no nerve input telling it to contract, then they atrophy. Moving on to Parkinson's disease. So the clinical syndrome for Parkinson's is this word right here, TRAP. Just remember TRAP. Tremor, rigidity, akinesia, postural instability. Those are the four main symptoms for Parkinson's, and just remember TRAP. Also characterized by cognitive problems, some sleeping issues, and speech. 1 in 2 per 100 people, and the issue is dopamine is the issue with Parkinson's. So, etiology, exposure to certain toxins. You guys know who Michael J. Fox is? Okay, so he has Parkinson's now. However, back in the 80s, before he was really famous, he was on a TV show, And like 3 or 4 people from that TV show all now have Parkinson's. So they don't know if something was there, like some toxin was on that set or something they got exposed to, but when a bunch of people can develop Parkinson's from one area, it's pretty weird that, obviously there's things that can cause Parkinson's to develop, which is why you ask about what? Work history, occupation. What do you guys do? What are you exposed to? Drugs can also do it as well. They may be reversible. Repeated head trauma. Who's there a very famous person who had Parkinson's? Muhammad Ali. He was a boxer. Repeated head trauma. Developed Parkinson's later due to the repeated head traumas from boxing. And there's a genetic component as well, familial and 5%. So what's going on with Parkinson's disease? Selective degeneration of those dopamine-containing cells. Okay, what color is dopamine? Black. That's what gives it the substantia nigra color. Nigra because it's black, dopamine. When you lose dopamine, the substantia nigra becomes paler and paler and paler because they can't hold on to dopamine anymore. All the dopamine holding cells have been destroyed. You can't hold on to it anymore. Obviously, you don't know that until autopsy to see if the substantia nigra has changed. There are more scans coming out now. They're called functional MRIs. They put you in an MRI machine, they do something to stimulate you in some way, and they see what parts of your brain glows with activity based off of that movement. And they can see some areas that should be glowing with activity don't, and they think that may be leading to a way to diagnose people with Parkinson's. Another thing is this thing called Lewy bodies that you may see with Parkinson's patients as well. They're found in the substantia nigra, so they're already in that area. Sticky white protein that's found in patients with Parkinson's disease. So there's this protein called alpha-synuclein, and that makes up the main part of these Lewy bodies. They think what's going on is there's a genetic defect that causes overproduction of that alpha-synuclein. Too much of it builds up, and they form these things called Lewy bodies. So if you ever hear of Lewy body dementia, that's what this is. These are Lewy bodies. So I think I talk about Lewy body in a second, but anyone know who had Lewy body dementia? Robin Williams. One of the main side effects of Lewy body dementia, one of the symptoms that makes Lewy body dementia different from other forms of dementia is hallucinations. Lewy body dementia has hallucinations. The other ones don't. And that's what Robin Williams had. So you can see here, it's the dopamine. We don't have enough dopamine to have an effect as a neurotransmitter, so you lose your function in anything that requires dopamine as that neurotransmitter. Okay. This is a non-generational humor, so you guys should be able to get this one. Okay. So you can see here, substantia nigra, they change in their pigmentation because you lost all that dopamine. So there are 3 normal molecules that are involved in apoptosis. So that's normal programmed cell death. Alpha-synuclein, we already talked about, parkin, and ubiquitin. So if a patient has a defective parkin gene, cell death doesn't occur. Apoptosis doesn't occur because we have an abnormal parkin gene. So we can't degrade our proteins as well as we should. Okay. Another thing that happens, this alpha-synuclein accumulates as those Lewy bodies, and it starts to deposit fibrous tissue. Do you repair fibrous tissue? No, it's dead. That's why you start losing dopamine cells here, because the fibrous tissue is dead. It deposits the fibrous tissue, kills the cells. So we lose our terminals, therefore impaired motor performance. We don't have the dopamine anymore that allows us to do those things. The role of ubiquitin is to mark the proteins to be destroyed. So ubiquitin says, okay, that's a damaged cell. This one needs to be taken care of. But because the ubiquitin is also damaged, it doesn't say this is a damaged cell, this is a good cell. So all those damaged cells stick around more because the ubiquitin is not working. Also, we get these beta amyloids, which also increase the buildup of synuclein. Beta amyloid is a known factor in Alzheimer's and may explain why people between Alzheimer's and dementia have similar presentations because of these beta amyloids. That's the link between Parkinson's and dementia. Okay? Because some patients with Alzheimer's disease will have Parkinson's type complaints as well because of the beta amyloids. Oxidative stress is also a cause as well. So what's going to happen in Parkinson's? Defective parkin allows abnormal growth of those Lewy bodies. We get beta amyloid production, which also increases alpha-synuclein, further making accumulation even worse. So all this extra alpha-synuclein accumulates as those Lewy bodies. Ubiquitin mutation responsible for no protein degradation, continued accumulation of Lewy bodies, and eventually going to destroy your dopamine terminals. And that's how the cascade works with Parkinson's. Start losing dopamine. So you can see here, this is what a Lewy body looks like under the microscope. Okay, so dopamine neuron destruction now results in motor function. Yes?
So are Lewy bodies always present in Parkinson's or only in Lewy body?
The Lewy bodies are in Lewy body dementia because it's a link between, it causes the dementia type, but Lewy body is formed via all these issues of Parkinson's. So dopamine destruction, what's going on with our motor function? So there's two pathways that dopamine works on, the direct pathway and the indirect pathway. Okay, the direct pathway is going to excite the motor cortex, allowing movement to happen, fine control, blah, blah, blah. The indirect pathway is going to inhibit motor cortex. Slow, fine movement allows you to, when you get into a table, you can stop because you know you're going to touch it. Those coordinated movements. So in a normal function, dopamine will activate the direct pathway, and it's going to inhibit the indirect one, so we get excitation, and we can get movement, coordinated movements, because it activates the direct, inhibits the indirect, therefore we have movement. Now, we're in a Parkinson's state. We lack dopamine. We don't have any dopamine anymore. So no activation of the direct pathway to excite it. And we're not inhibiting the inhibition one, or the indirect pathway. So the indirect is going to win out now. We get inhibition of the motor cortex. And that's why dopamine has its effects in the body. It doesn't stimulate the direct pathway anymore, so the indirect wins, no movement. And that's Parkinson's. So cardinal signs of Parkinson's, when about 70 to 80% of those dopaminergic terminals are destroyed. So just like with the kidneys, you got to have like 60 to 70% of those nephrons destroyed before you start seeing signs and symptoms. Same thing with the substantia nigra. 60 to 70% destruction before you start seeing some symptoms of it. So rigidity, tremor, bradykinesia, loss of postural reflexes, the TRAP signs. Rigidity is lead pipe rigidity or cogwheel. So you guys do your dance, that passive movement, follow me doing all those things. They're going to be like very stiff, like a cogwheel, like a click, 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 click. Not a smooth motion. It's going to be sporadic. And that's why you do your dance, follow me. You're watching them, how do they move, so forth. If they have rigidity of the trunk, gait and postural abnormalities, they're going to walk like this. They won't move their arms when they walk either. They're very rigid when they walk. Yes?
So with the abnormal function, it kind of sounds like then there isn't any movement and they would almost be paralyzed, but is it because of the 70 to 80%?
Yeah, I mean, you still have movement. You're not totally out.
Like the tremor part, though, is that like...
That's part of it as well.
Part of it being inhibited, but you can't control it?
It's not really control. Remember, these are coordinated movements. We don't control these movements at all. Okay. So that's why we do certain tests to see What test do we do in lab for coordinated movement?
We could do rotator maybe, or just okay.
Hand flap, shin. These are coordinated movements that people with cerebellar problems can't do because of the being able to control their movement. They lose the control, so that's why everything's like hard to move.
Okay.
Okay. Shuffling, hasty gait. They accelerate the steps as they're walking because they figure they lose balance, so they start walking a little bit faster. Some clinical manifestations, more resting tremor. Stops with a voluntary movement. Very important for Parkinson's. They're going to have a resting tremor. But you say, okay, fine, touch my finger. As they come closer, the tremor goes away. So with purpose, the tremor goes away. Involuntary, they're going to have a resting tremor. Okay? Hand tremors is called pill rolling. They sound like this, and their fingers will just keep doing this. This is pill rolling. This is a sign of an extrapyramidal symptom from a drug, for example. Haldol is a big one that has a lot of extrapyramidal side effects. Take them too much, they start doing this, or like lip smacking. Those are things from extrapyramidal side effects. Akinesia, bradykinesia, problem initiating movement. So they're, hey, walk towards me, and they're like revving up, and then they go. So that's initiating of movement. Expressionless face, it's also known clinically as masked faces. They just have no emotion on their face at all. Loss of postural reflexes, poor balance, disturbed gait. Again, loss of arm swing during walking. Turning on block, that's that shuffling when they turn around. They can't just like walk into a corner, turn around and walk. Micrographia, they start writing very, very, very small as well. So that's changes with Parkinson's. And here's your summary for Parkinson's, and then some faces of Parkinson's. There's Michael J. Fox. And here's a good one for all you ER people. And then we'll take a break. Come back at 1:30.